I just want to find out from the people online if you can hear me. Do you have sound?
Yes, we can.
We can hear you, Shante.
Okay, can you? Okay, good evening, everyone. It's really good to have you, and I hope you've grabbed some snacks. You will notice everything is vegetarian and halal. Please don't be too angry at me for that. We are trying to slowly, besides save a bit of money on catering, considering budget costs, also try and be a bit more sustainable in the way that we cater for our events. All issues are in any case intersectional, so yeah, please do grab some to eat. If there's leftover when we're done, or if you're feeling a snack while we're busy, you're more than welcome to grab some, because I also don't want to waste anything. Okay, so basically, to first say a huge thank you for everyone in attendance, online and in person. We really had a very big reach. So we had about 230 RSVPs. Obviously, there's always no-shows, but you can see that we really have quite come out in numbers, and it's really exceeded my expectations. Thank you. Okay, so as I said, we had a very wide reach, really spanning beyond UCT. Of course, we had a lot of people from the Faculty of Health Sciences across departments and divisions, but we also had people from different faculties. Beyond that, we had people from different hospitals across the country, different factions of government, colleges, organizations, associations, and NGOs. Just to name a few, we have presence from Stellenbosch University, main campus and mid campus. We have UNISA, we have WITS, we have UP, even University of Montreal. We obviously have presence from Kruteski, Red Cross, Steve Biko Academic Hospital, Tygerberg, Netcare, and then Department of Health, Department of Education, WCD, Western Cape Government, and then even, as I mentioned, NGOs, Desmond Tutu Health Foundation, Iranti, Gender Dynamics, TB, HIV Care, Triangle Project, and everyone has spanned such a wide range of positions. We have pharmacists, we have people from media, consultants, MOs, dietitians, social workers, psychiatrists, psychologists, honestly the works. And for that, I really just want to say a very big thank you, and I think we deserve a round of applause for that. And then, yes, so just thank you for taking out time from your frighteningly busy schedules to kind of take the small step to make healthcare that little bit more inclusive and to be a better person and best practitioner for your trans patients, clients, colleagues, and students. Okay, so that brings me to the proceedings. So obviously I have my introduction now, and then I will then introduce our keynote speaker, who will speak to us for about 10 to 15 minutes, just a bit of an introduction, contextualizing and such. She will then introduce our other panelists and go on to facilitate a conversation for about 50-55 minutes, which will then take us into a Q&A, where we'll have about 25-30 minutes, depending how things go. So I just want to ask that you keep all of your questions for the end, because then we can just give the conversation the time that it needs to develop and time for information sharing, but then we'll also give the audience the time that they need to ask questions and to engage as well and give comment and such. And then lastly, something that I forgot to do is introduce myself. I'm Shante Arab, and I'm speaking to you because I am the Gender and Sexual Diversity Advocate for the Faculty of Health Sciences here at UCT. Okay, so that takes us to our keynote address. So our speaker is Gita November, pronouns she, her. From a small town in the Northern Cape called Sutherland, determined activist and transgender woman Gita November advocates for greater access to gender-affirming healthcare. In this regard, Gita serves as the Health Advocacy Officer at Gender Dynamics and also works at the renowned WITS Research Institute that specializes in HIV and TB and sexual and reproductive health, vaccines and infectious diseases. She is also the executive director of an NPO called Transgender South Africa, which she founded in 2021. Gita is a renowned speaker and educator, focusing on topics related to gender-affirming healthcare, empowerment of LGBTQIA+, and other marginalized communities, sexual and mental health, among many other things. Thank you.
Thank you, everyone. Can you hear me? Can you hear me now? Hi, everyone. So I am Gita November. And just to add on to what you were saying, I am from a small town called Sutherland in the Northern Cape. Is one of the coldest places in South Africa and one of the darkest places in the world. But also, when it was the darkest, I decided to become me. So I am here today, 40 years later, born in a small town, but also I think what you have forgotten to say that I was also a sex worker. So for many years, I was into the trade, and I've exited the trade, but also I'm just dabbling sometimes into the trade too, again. But today I'm not here to talk about sex work. Today I'm here to talk about the state of transgender healthcare in South Africa. As a transgender woman myself, I'm privileged to being invited here and being with our esteemed guests. But what is our current state in South Africa? As a trans woman myself, I had to struggle to get to where I am today. I had to jump through the hoops of pathologization to making sure that it's just to get legal recognized in this country. So in order to do that, I had to put my body through a lot of things. So when we talk about transgender healthcare, it is very much important for this country to have you first fixed into a point, and then you can be recognized. So what I want to address about this is the year 2019 marked a significant milestone for the transgender individuals in South Africa as the South African National Essentials Medicine List Committee granted approval for gender-affirming hormones to be included in the tertiary level care. Today, I stand here 5 years later after this groundbreaking decision to discuss the current state of gender-affirming healthcare. Well, I'm here talking about it. Despite efforts to address healthcare disparities on a global level, public health research and policy reform have largely overlooked the structural mechanisms that perpetuate the exclusion of transgender patients within the healthcare system. The issue of healthcare status is frequently characterized by extreme inequality, and the historical design of our healthcare system continues to be a significant challenge for many South Africans. It is crucial to acknowledge only not the transgender experiences, but also the broader LGBTIQ+ a community when accessing gender-affirming healthcare in South Africa. In October of 2021, the Southern African HIV Clinician Society published the Gender-Affirming Hormone Care Guidelines for South Africa. However, transgender diverse individuals in South Africa continue to encounter discrimination and stigmatization within healthcare facilities. This has resulted in limited access to care and increased health risks, secondary victimization, when seeking healthcare in South Africa. Existing studies have shown that 82% of South African transgender adults receiving gender-affirming healthcare at the Steve Biko Academic Hospital, Gender Reassignment Clinic in Gauteng, and the Grooteskië Transgender Clinic in the Western Cape reported experiencing social exclusion due to social stigmatization of their gender identity, particularly from family members. These experiences have been found to be significantly associated with psychological distress. This situation continues to marginalize transgender and gender diverse individuals in our clinics and hospital. Access to gender-affirming healthcare remains a distant reality for many transgender individuals residing in rural and township areas across the country. Gender-affirming public health systems and specialized transgender units are still limited, with only 3 hospitals currently offering dedicated transgender units, 1 in the Western Cape and 2 in Gauteng. This scarcity continues to be the backlog of cases faced by these hospitals. Another great challenge that our people are faced with is the accessibility to gender reaffirming surgery, which for most trans persons remains a privilege and a dream. Beyond the obvious high costs of the procedure, it also takes up to 20 years to receive this essential service if you go through the government route. Transgender people from rural areas of provinces where gender-affirming healthcare is not available must travel long distances to major cities just to access these services, going back and then coming back again. We continue to advocate for the National Department of Health to adopt guidelines published by the Southern African HIV clinicians. This adoption would provide a framework for standardizing and improving gender-affirming healthcare practices across the country. With the adoption of these guidelines, we are taking steps closer to decentralizing gender-affirming healthcare practices across the country. The decentralization is crucial to ensuring that transgender individuals have easier access to care they need, especially in these underserved areas. It is crucial to advocate for policy changes and institutional support to ensure that transgender individuals receive the care that they deserve without facing discrimination or barriers. I eagerly anticipate to unpack and delve deeper into the dynamics of gender, the complex dynamics of gender-affirming healthcare with my panelists. It is worth nothing that this engagement is taking place in an institution of higher learning. Such institutions serve as microcosms of society, and therefore it is vital for the academic community to foster these social debates. Thank you, everyone. And now it gives me also pleasure to introduce the 4 very dear panelists to my heart. So many of you might know that also when I was introduced, I said that I worked with Witch RH. I'm not with them anymore. I was just part of the opening of the clinic, and I'm very, very honored to share the stage with Elliott, Kotze, and Dr. Anastacia Tomson, as they were with me when we started the clinic in Bellville and opening the 4 clinics across the country. So Dr. Nicole Chilimigras, so from Johannesburg originally, where they completed their undergrad MMBCH at Wits University, Dr. Chili was privileged enough to be placed in the rural Eastern Cape for medical internship, which was completed at Nelson Mandela Academic Hospital in Mthatha. After falling in love with rural medicine, they decided to do rural community service in primary healthcare capacity at Zulunteli District Hospital. I don't know if I pronounced it correctly. My mother tongue is Afrikaans, so please do bear with me. They stayed on the extra year for learning purposes. The 2 years spent at the facility provided invaluable academic and personal growth. So Dr. Chili has been pursuing special treats in sexual health, mental health, including neurodivergence, chronic and overlapping pain conditions, as well as queer-affirming healthcare, whether gender, sexuality, or otherwise. Chile is now part of the South African Sexual Health Association, National Executive Committee as part of the executive portfolio. Can we just give Dr. Chile a hand, please? And someone also very dear to me. Ron Addinall. Gender non-binary queer identified. Ron is clinical social worker, sexologist, and academic at UCT with over 30 years professional practice experience across many fields in social work. He developed an introduction to human sexuality workshop for healthcare practitioners, which he presented through South Africa in the public, NPO, and private healthcare sector. Ron is a founding member and past board member of the Southern African Sexual Health Association and a founding member and past board member of the Professional Association for Transgender Health South Africa. Ron is internationally and nationally regarded for the expertise in sex therapy and sexual health, as well as the particular areas of ethrology, transgender and gender diverse, gender affirming psychological healthcare, as well as diverse sexualities and communities. He serves on the transgender clinical multidisciplinary team of Kotze Hospital. He serves on the WHO task team for South Africa for the clinical utility research on the ICD-11 diagnostic criteria for gender incongruence and Thank you. Ron serves as a specialist member of the research and writing team who, under the auspices of the HIV Clinician Society, published the first ever gender affirming healthcare guidelines for South Africa in 2021. He is also a doctoral candidate working on his thesis, The Psychosocial Experiences and Healthcare Needs of the Transgender and Gender Diverse Minority Groups in South Africa. So we can give Ron also a hand of applause. The next person, I also know this person fondly as Wofsian. Yes, Elliott Kotze. Elliott Kotze is a queer trans men counseling psychologist and researcher with extensive experience in gender affirming healthcare and queer sexual health, offering a welcoming space for adolescents and adults to engage with and explore various aspects of their lives and identities. My services encompasses both brief and long-term therapy. It is not your services, but mine, no? For adolescents and adults, designed to address a range of critical concerns from the intersectional point of view. His work broadly focuses on improving the quality of life of queer and gender diverse folks through the strategic implementation of community-driven interventions. His expertise extends to the navigating to the complexities of diverse relationship dynamics, including kink and BDSM. Polymer. Can you help me with this word? You know, it feels like my mouth is rolling like this with this words, you know? Swinging in open relationships. Elliott is based in Muizenberg. Can you hear that? Muizenberg, Cape Town. He also offers research and facilitation services to organizations and larger groups and serves as the Western Cape chair to the Southern African Sexual Health Association. And then why? Do you know why Elliott is called Wofsian? A hand of applause for Elliott. And then, of course, my angel, Dr. Anastacia Tomson. I think she don't need any introduction. It's like, we're just like, do you want me to move on? But I do want to say something about you.
But then you have to go off script.
It's going to take me 3 hours to conclude that.
Stick to the script.
Medical doctor, author, and activist Anastacia Tomson has a well-established track record in upholding human rights for LGBTQIA+ individuals and her work in expanding access to competent and sensitive healthcare for minority groups. Anastacia is an experienced primary care doctor with special interest and expertise in trans and LGBTI healthcare, vegan nutrition. Oh, we heard that there was vegan food outside, so we have it already. Exercise medicine, eating disorders, and mental health. She's a public speaker and educator. She regularly lectures undergrads, medical students at UCT on the subjects of gender and sexuality. Anastacia is also a founder of the Professional Alliance Combating Transphobia and Sexual and Reproductive Justice Coalition Steering Committee member, recognized as the Mandela Washington Fellow, as one of the Mail and Guardian's 200 Young Africans and one of the Young Independent Mzansi 100. Anastacia has contributed to multiple local international publications and led to the process of producing and publishing South Africa's guidelines for gender-affirming healthcare. She has also written her own autobiography, Always Anastacia, The Transgender Life in South Africa, a compelling memoir told through the lens of transition. So I will be joining them on the stage. It's really happy to being here with you all today. I want to acknowledge everyone in the space and thank you to projects, and supporting others, organizations that is here. So thank you. It shows that we are in solidarity for what we are standing for. And all the way from Johannesburg, Iraq is also in the space, so it is quite a big honor for us. So, Chili, hi. So you fell in love with rural.
I fell in love with primary healthcare after training as a major student, as we all do, trained to be a specialist. I thought I would be a surgeon, tangible problem, tangible solution, and as all good plans that were completely out the window when I was full grounded for internship.
Yeah.
And then I really fell in love with rural medicine because when you like it or not, you make more of a plan than what you have resources available to you, and I quite enjoyed that way of thinking. And then during my community service and after that in a district hospital, I realized what a difference you can make in primary healthcare. And so even though it's not as sexy as Grey's Anatomy and intubating someone and putting in chest drains, I actually think there's really something integral and beautiful, and there's so much opportunity when it comes to meeting people at a primary health level, as well as possibly even primordial healthcare level, because education is really what I'm passionate about. Sex ed for adults specifically. And I think that if more of us did the primary healthcare a little bit better, then there'd be a lot less unnecessary referrals to high levels of care and that kind of thing. Yeah. So that's where I found my primary healthcare, and then kept on side to put my feelers into sexual health, gender-affirming healthcare, and then that overlapped and unfolded into mental health, chronic pain, also the special interest in neurodivergence, which of course there's some overlap. So yeah.
Yeah. Okay, we're going to tap more into the primary healthcare, because just looking at Anastacia and I think you must have seen yes, it's your fault, because it's your fault that Glenn come to see me. But looking at the primary healthcare lens, and I think when we started, when we had the opportunity to create a service delivery to trans people through the RFI, we saw that primary healthcare is the way to have this decent. What you thought of it when it comes to transgender healthcare process?
Absolutely agree with you. Very clear. Yeah, absolutely agree with you, Gita. Just for those who are not familiar with the BITS RHI trans health clinic model, I'm not going to go into the model in detail, of course. But basically what they did was start a primary level clinic specifically for trans women, trans feminine people to access hormones specifically, and STI screening and treatment. So that was the combination. It was used to as sort of a trial run to see this this thing that was promulgated the year before. Can we mainline? Please make us mainline hormones. Can we streamline the distribution introduction of hormones, HRT, through primary healthcare clinics. And what we saw there is, yeah, absolutely, this is where we're going to reach most people. Because as things stand currently, I mean, you mentioned briefly the 23-year, 25-year waiting period with Kotze or whatever. I mean, if you are a public patient at the moment, your options are either you pay for your hormones yourself, which for most South Africans isn't really viable, or you get it through Kotze or whatever primary level doctor you can maybe find. There somewhere, I guess. But the thing is, that is a major barrier to access. So yeah, I think there's much to be thought about still around this and the sort of barriers to streamlining it in primary healthcare, but absolutely vital if we want to expand access.
Yeah. So I just want to direct this quickly to Ron, because when I introduced you, you were curious about disciplinary. So what is the current state of gender-affirming healthcare? When we look into the Kotze lens, if we look at like talking about Kotze, so let's just talk about it and see what is the
Happy
current
to.
state.
So the current status of the word that, whenever I read that question, the first word that comes to mind is patchy and limited, is probably the summative description I would give it. I think the transgender clinic at Kotze, which only got itself going again in 2009, and one of the longest standing, clinics within a tertiary government hospital, has been working very hard as a multidisciplinary team to try and maintain and ensure that the limited services that is access at Kotze is maintained. I know it has a reputation of being the longest standing, but what people don't know in the background is to keep it going. Every now and then it gets challenged. So accessing hormones for the limited number of trans and gender diverse persons who can find themselves at Kotze Hospital referred there are getting access. But the point we're all making is we do know that the need is significantly larger across the entire province, not even talking about the other provinces which you highlighted, where the need is. So the primary health care theme that we are emphasizing here, I just want to kind of keep it in the center because that's where we need to be moving to. So the clinic there can give access to gender-affirming hormone treatment to a limited number of persons, and then you get placed on a waiting list. Dr. Kevin Adams you were referring to. So Dr. Kevin Adams being the plastic surgeon that's been part of the team since we got them going. I mean, from when we started there, in 2009, the hospital was allocating 3 to 4 surgeries per year. He has not been able to get that number up, and we've done all kinds of programs and projects, as well as trying to even kind of get private medical aid, to kind of consider being inclusive with gender-affirming healthcare, both hormones and surgeries. So I think the status is for me, I see the clinic, almost is going to sound very arrogant and narcissistic, but hey, here we go. It's very similar to kind of the people that are here on the stage and our fellow tribes, healthcare practitioners around the country. But the status is very much dependent on who is there and willing to stand up and do the work. And the moment someone moves away or can't anymore, services fall away. And that's what I mean by patchy. We haven't yet achieved that place where it's a recognized, form of care that is, whether you go to your clinic to go and get your diabetic meds, your blood pressure meds, you're going to go get your gender-affirming healthcare, whether it's your hormones. Yes, obviously the surgery will stay in the tertiary kind of domain, and that's work that needs to be going. Then I can plug my own kind of emphasis that I think I bring to this kind of mix here is, yes, medical healthcare or medical gender-affirming healthcare is important and critically important. But I find the part that's often not also understood is the psychosocial healthcare needs of the trans and gender diverse communities as well, which is the areas I work in. So you should be able to go to the clinic and see the doctor to address the medical aspects, but you should also have your psychosocial mental health care practitioners at that level as well, where the person can be offered the support on, I'm struggling with my identity, I'm still trying to figure this out. I'm struggling with a range of, whether it's depression or anxiety or whatever it may be. I'm also struggling with the fact that I'm coming out, I'm in a marriage. I'm struggling with the fact that I'm needing to transition, but I have children. I'm struggling that my child is come out as trans and I'm accepting them, but now I have to face the school because my child needs to socially transition and be their true authentic self at the school. I mean, that's just a few examples. I mean, I'm in a relationship and I'm transitioning and it's impacting the sexual relationship of my life with my partner, and we need a space where we can talk this through and navigate this with someone that can offer some guidance and expertise. So for me, I just want to say that gender-affirming healthcare is much wider than just the medical healthcare elements of it as well. I'll stop there.
Yeah, and on that note, I think I'm directing the question directly back to Anastacia. Doc, you are the medical doctor, so I would really like your thoughts on what we just discussed now, and just take us further into that.
Yeah, I'm going to say three things, Gita. And most of them are things that I always say, so I won't bore you with this. But the first thing is just to say that gender-affirming healthcare is, again, not just hormones and surgery, but it's everything. If you cannot go to your local clinic and get treated for a common cold or for hypertension or for diabetes because you're going to be misgendered or dead named and it's going to put a bullseye on your back, then our healthcare service is discriminating on the most fundamental and basic level. And as we said, trans people are not, our existence is not a new phenomenon. It's not geographically distributed, only concentrated in the centers where the tertiary services are. There's trans people all over South Africa, and we have a primary healthcare network all over South Africa. So it's not enough for us to say, all right, this is, I'm not saying it's not important, we must push for getting hormone therapy into the EDL at the primary level, but we need basic education, sensitization, competency training for all levels of staff in primary healthcare, and that starts at the security gate, and the admin clerk, and the janitorial staff, and the nurses, and the social workers, and the psychologists, and the doctors, and the facility manager. The second thing that I want to say, and it upsets me, but I even have to say it, but access to healthcare is a human rights issue. And we live in a country that espouses constitutionally policies of non-discrimination. But the conversation has become a political one and baffles me. It absolutely baffles me that human rights can be subject to a political debate and that the dissemination of malicious misinformation is so prevalent, and it's co-opted by actors with their own agendas. And what we're doing is throwing marginalized folk, trans folk specifically, especially younger trans folk, under the bus. And it costs people mental health, well-being, housing, shelter, education, and their very lives. So for us to have a debate around these madcap, rogue healthcare professionals that you see in front of you on the stage, who are starting people on hormone therapy at the age of 4 and doing irreversible surgery in the utero, like, you don't do that. You don't do that. I can think of one scenario where irreversible surgical procedures related to sexual anatomy are performed on children, and that's for intersex kids, because we don't ask them, we don't allow them to give consent, we just operate on them to make their bodies more acceptable to our idea of what they should look like. So I feel like I need to call out that double standard, and I feel like it needs to be said. And then there was definitely a third point that I wanted to make. And for the life of me, I can't remember what it is. So I'm going to shut up.
Yeah, so, yeah, please do. But I would like to say that when it comes to the political situation within our country, it's also, I don't know, I just want to make this example. So we are all sitting here, the same people, we have to vote. I can say yes, don't cut me down and I don't take anything away from me until you have power. But also it comes back when even as much as it's political, the legislative also, because we have also challenged that is this in your curriculum? Is this because we can talk about sensitization, but it is not in the curriculum of the health science, then what are we doing here? Are we sitting here just to show face that we are here because in the face of diversity, in the face of movement, we want to do this, but how serious are these institutions about what we are saying here? Yes. Oh, sorry.
Just having one of those days. The third point, yes, it's very important, I'm sorry I forgot it, is just to say that we are health professionals. This conversation is not limited to health. It has to incorporate Department of Basic Education, Department of Higher Education, social services, justice. This is intersectional. All of these different components are linked. And what we're doing is we're kind of chasing our tails and trying to clean up at the back end. We're taking people who have been through basic education, secondary education, higher education, and then we're saying, oh good gosh, now we have to sensitize them around the existence of transphobe. And the fact of the matter is that this is because we missed the buzz. We needed to start having these conversations at a level of basic education, where the conversations also become politicized. But it has to echo through all government departments, or else we are not doing enough.
Dr. Chili.
I just wanted to jump in to mention something from what Stace and Ron was saying. And in your introduction, you mentioned how sometimes part of, not sometimes, always, if not very often, how when it comes to the way in which things are structured, it can impair access. So a small example that you gave, Ron, about how there is a transgender gender-affirming healthcare clinic. Clinics are usually primary at Kotze, which is tertiary, if not quaternary. And so then theoretically, the doctors that are working there are tertiary level individuals, and so then patients, or clients rather, because many patients are sick, and not everyone seems sick, so if you're trying then, you land up potentially seeing a super specialist endocrinologist to script you something that a primary care doctor could have. It's a bit scary because it sounds cross-sex hormones. But when it comes to primary healthcare level, the double standard again is you don't mind giving 16-year-old females contraceptives. It's hormones. You don't mind treating peri and post-menopause and menopause with hormones. We know even for gents as they get older, for menopause with the low testosterone. We also know that some people want to go on meds to clear their skin. Some cishet dudes want to go on meds. For me, that's cisgender gender-affirming healthcare. If someone's taking testosterone to get buff for the gym and they're cisgender, it's obviously very different, and I'm not saying it's the same at all. But the point being that if and when we are concerned about being safe, let's try and use that same intervention, but for a different individual, to try and highlight and illustrate to us have some unconscious biases we may have. And that's what leads me to my next point, which is I completely agree that it has to start in med school at the very least, if not earlier on. Because the way we get trained in med school is us and them. Us clinicians, them patients, and it's a class of 300. There's zero chance in the class of 300 that there's not someone with diabetes or with depression or with gender diversity and. But it's always us and them. And so we get trained and tortured in a specific direction so that we are always the correct, knowledgeable, confident individuals in the room. Because you can't err, you must know. And I think that sets us back quite a lot. because, and especially in primary healthcare, sometimes you're seeing people to help them feel better. You're not always seeing people to diagnose pathology. And so I think there's a lot of space there that we can improve what we're doing. Small, big things, like part of our training view. What is the emotion I'm feeling? Is this a me thing or the other person thing? A bit of self-awareness, a bit of a trauma-informed lens, understanding intersectionality, understanding that gender is a social construct and how has that influenced us in our lives thus far? How has it influenced us in our practice? And how can we change that going forward? So when it comes to decentralization and having access in primary clinics, it's so, so important because exactly what Anastacia was saying now, there are not enough tertiary centers everywhere to provide that access. And so if we continue to only hold the conversation for specialist level of care, number one, we're not understanding gender. Number two, we're not providing access. And of course, if and when there are gold standards that we maybe can't meet because of resources, well, what's the second best? And let's try for that.
Yeah. Ron, yeah, you can give them that. So I just want to ask you a question with regards to the decentralization of gender-affirming healthcare. Looking at from where we landed and what you just saying now. So for me, a question: how does it work out?
Sorry, I said if the capacity was fantastic, otherwise we might have to take it to the future. Because it looks like the installing inside there.
When we look at how realistic will it be and how far can we
disappointed.
Me too.
That's realistic. My immediate response is absolutely realistic. Because what needs to happen can be clearly described. What needs to be, where the realistic, using that phrase is, the obstacles that I'm seeing most often is attitudinal, it is people's particular perceptions, their biases, their prejudices, that are what are standing in the way. If we could get all of that out of the way, I think to create the map of what a ideal primary health care center would need to look like, and what the range of services are that should be there, and resources, that is not rocket science.
Yeah.
Because all the research has been done, all the evidence-based stuff is already out there, both on the psychosocial and on the medical side.
Yeah.
It's about, is there both governmental, political will to make this happen? And for me, the obstacle to the will is at the level of, well, and I want to say ignorance, but I get angry when I say it, because we live in a time, you've got a fucking cell phone. How can you claim ignorance at this point in time? But, let's be nice. But it's not an excuse anymore.
Yeah.
But there's willful. And I'm part of the WAS's Transgender Committee, who recently had a meeting where they presented to us the organized international movement and funding by means of particular organizations that have political intentions that are behind this ongoing propaganda, misinformation, and trying to kind of break down where rights already exist, and the influence on the African continent. So I think it's absolutely doable, it's absolutely achievable, if it's in the hands of people that are wanting to do it and just follow what we already know needs to happen. But it's that level of obstacles that we need to still navigate.
Elliott, do you want to add something to that?
I mean, I can.
Yes, I want to.
I think just one thing hasn't been touched on as part of this bigger medical apparatus, and something that I had a run-in with recently is medical aids.
Yes.
Because medical aid systems override all systems, and I know this as a therapist with practice management software. If I use the medical aid details for my clients, then the details on my system will be the details on their ID service, right? So whether or not that fits with who they are doesn't matter. Now, my ID has changed. I am M, on my ID and on my medical aid. But when I had to get a hysterectomy procedure, Discovery said to me, oh no, but we can't do that because it's only for Fs. So after keeping me on hold for a lot of minutes, they came back and they said, okay, we can do this, we can cover this, but we're going to have to change it to an F. By this stage, I was like, okay, no, whatever, just pay for it. But I was thinking to myself, like, do you know how long I waited for that M? Do you know how I had to fight for that? And now you're turning it around. And I mean, I promptly conferred myself a PhD to avoid being misgendered at the hospital, because otherwise I would be missed. With a beard. You should see the nurse's confusion. Anyway, the point is that we also need to engage the medical system at that level. Because also in the wake of that, my partner and I started following up with some other medical aides to hear what if someone was an M but needed a hysterectomy, would you cover this? And the answers were no, no, no. So this is that's,
Yeah.
yeah. I have an organ that's making me sick, it needs to be removed. You're not going to remove it. Anyway, yeah, that's my little bit.
Thank you. So before I'm going to ask the panelists to just engage further, can I ask anyone in the audience that they have a question for our panelists? Yes.
Hello everybody. My name is Janet Giddy, and I'm a family physician and public health consultant. Thanks for this discussion and this opportunity to ask questions halfway through. So I really appreciate that. So what I want to say is that medical doctors who want to practice ethical and safe medicine need to be guided by scientific evidence. And this is particularly true when it comes to the care of vulnerable populations such as children and adolescents. And in these situations, we need to rely on the very highest quality of evidence. Now, I've heard one or two references to somebody saying that, I think it's yourself, you have adolescents in your practice. So yes. People haven't really distinguished when they're talking about gender-affirming care between adults, adolescents, and children, although I've also heard some references to the Department of Basic Education. So we're implying something around children. So I think my question is really to ask you, whichever of you want to speak about it, is to comment on the evidence base of providing gender-affirming care in children and adolescents specifically. That's my question. And what is the evidence base? How strong is it? And yeah, to speak about that if there's time.
I don't think I can be covered.
Yeah.
You haven't done this, so I have to walk on it. Yes. Also not for those shoes. So I'm not going to talk to the evidence base as much because I don't have the citations on me, and it sounds like that's what that's what you're looking for. I do want to just clarify as it seems like you requested. So yes, I do work with adolescents in my practice. I don't work with children because I'm not set up for that. What is gender-affirming healthcare for children? Pre-puberty, social transition. Mommy, I don't want to wear a dress. Okay? Mommy, my name is not Emma, it's Bob. Okay? Is it going to make a major difference in their life? No, not. Is it going to make them feel maybe a bit better about themselves? Yes. When it comes to adolescents, at the moment, that depends on where the adolescent is. In my limited experience with the adolescents I've worked with, they generally don't push for the hormones until they're ready for it. In fact, they think about it quite hard because they get a lot of questions around how do you know, how you're not old enough to know, all of these things. So they really are forced to really engage with this. So with the teenagers who do go on hormones, there's a immediate and clear difference in their mental health. Without fail, I'm not an advocate for prescribing hormones to every dog, dick, and sequel. But I also don't think every dog, dick, and sequel will ask for hormones. Even with adults in my practice, a lot of the work, if I see someone who comes in a sort of a questioning phase or early in their transition where they're still thinking about the hormones and medical interventions, there's a lot of soul searching happening. There's a lot of internal gatekeeping happening, which I guess I'm saying this to say I think the gatekeepers can chill and maybe focus on something else because our own internal transphobia doesn't well enough for us. Yeah. So I'm going to leave it there. I don't know if one of you really want to talk to the evidence. Dr. Chili.
I would like to leave the evidence to Ron because he's been doing this longer than me. I want to mention how when it comes to medicine, anytime we consider an intervention, we know that there's risks and benefits of intervening, not intervening. It's never a neutral action. And I take that view with any child or adolescent I'm seeing, whether there's a bruise on the arm or a UTI, or perhaps gender diversity, sexuality diversity. I'm also of the belief that when someone tells me who they are, I believe them, unless there are other coexisting factors that I need to take into consideration. Anytime I see a person in front of me, I consider them today, the story that brought them to me, and what ecosystem are they part of. Is your ecosystem an inhibitor of your authenticity, or is it going to allow that? And within that, we need to see how can I assist you. Will I be helpful to a child, let's say they're 15, and they say, Dr. Chili, I want hormones today. I live with my parents, they pay my school fees, they will kick me out. Am I going to write them the hormones immediately, or are we going to have a discussion around, but wait, what are we aiming for right now? Is education not important? It's always a nuanced discussion. Whether we intervene or we do not intervene, it is never neutral, and we must be aware of that. There's no such thing as a one-size-fits-all. In the same way with any patient or any person that is of a vulnerable population, we know that children and adolescents are a vulnerable population. We also know that trans individuals and gender diverse individuals are of a minority. Then we consider all other interesting intersections like race, like geography, socioeconomics. And then we consider how I don't even want to do biopsychosocial, I like to do socio-psycho-bio, and then we take it from there. And then we see what we left with this one individual sitting in front of us, as well as taking into account all the other factors. That's much better.
Thank you. Thanks.
And Dr. Chili is a social worker presenting as a doctor. Okay, let me just get my thoughts come together. Okay, so the question around the evidence, it's often a loaded, I'm not saying I'm saying loaded question, but it's a loaded conversation. So I've been working in this field over 30 years. I'm now claiming old age and been around since Mar fell off the bus. And yeah, so I do work with families, I work with young children, I work with adolescents, I work with adults. And in the last number of years, most of my practice has been with young children and adolescents and their families, with particular focus on facilitating schools being inclusive, safe spaces and navigating, negotiating the social transition of young people in school spaces. And just to highlight, because still today, the National Department of Basic Education still can't get their policy and guidelines published, so every school is still a force unto its own.
Yeah.
Now, so that's the context, and I have worked with, I can't remember the numbers of kids now, so I'm drawing from that. To my knowledge and understanding from a evidence base, if we just take the recent updated WPATH standards of care guidelines, and all of the evidence research that was collated in then updating the new standards of care. What we also do know is that various international healthcare societies, the endocrinology societies, there's pediatric societies, etc., around various parts of the world have published studies. Some studies are small studies, some studies are slightly bigger, and they've been collated, and basically kind of bringing that all together has led us to where we are now with what is recommended when it comes to gender-affirming healthcare for children, for adolescents, and for adults. Now, where I'm going to go with this is often when you're engaging in this conversation, what parameters is in the mind of what is deemed, evidence enough? So it depends on the kind of the scientist's model, etc. So, for example, one of the debates that often come up is, well, the studies that exist are problematic because they're not double-blind studies. It is unethical to do double-blind studies in many of the gender-affirming healthcare environments. But I am very confident in the work that I've been doing in all of this time, and with having watched the evidence grow and develop and evolve over the last 20 years, that gives me great confidence in being able to work with young kids, with their parents, with their families, and absolutely, it is participatory approach. It's informed consent. Every child is, or every adolescent is a unique individual. Yes.
Yes. How many of the people sitting on the stage right now help write the South African guidelines that can give you all the referencing, citations, everything? Please direct people to that.
Okay, so what I want to say is, in my opinion, the evidence is very strong. There are contrary debates and conversations out there, and people do question it, but that in itself has to be examined.
Yes, so one last question, and then we just move into the others, just for time's sake.
Thank you, and thank you for that response, and I appreciate it, all of you who responded. I'm just responding because I asked a question. So I think you probably won't answer the question, but I want to say, can you comment on the fact that several countries, including the United Kingdom and several of the Scandinavian countries, are no longer recommending gender-affirming healthcare as the standard of care in young people with gender dysphoria? Can you comment on the closure of the Tavistock Clinic in the UK, because they had a very large cohort of young people? Can you comment on the recommendations of the PASS review? And lastly, can you comment on the evidence base of the WPATH SOC 8 guidelines? Because, when we talk about small studies, big studies, what's enough evidence, the fact is this is a very new field, and when we talked about vulnerable populations, children are vulnerable, and they need to be protected. And it's a very new thing that this gender-affirming care has been offered to children over the last 10 years in such large numbers. So there is actually quite a lot of evidence.
But what do you mean when you talk about gender-affirming care for children?
Sorry, I haven't got to the end of my sentence.
Sure, but
wait for the full stop.
Excuse me, ma'am. So
I'm just asking for clarification.
Yes, please, but I just, as the moderator, I need you to get to your point, and then also for us to discuss.
The point is, some of the panelists say very confidently things like, all the evidence is out there, all the research has been done. And my point is, this is a contested, controversial area. Children and young people are vulnerable, and I think it's important that in the discussion, we acknowledge that the deal is not done, and we don't really know sometimes what we're doing. And we sometimes, as the WPATH leaks show, we're making it up as we go along, and we cannot experiment on children.
Wow. Thank you.
Wow.
I'm not gonna, I know Gita asked all the time. What I just wanted to say, what I wanted you to clarify was, what do you mean with gender-affirming healthcare for children? Because it sounds like we're not talking about the same thing, but it seems like we're derailing the conversation. So where are the other hands? Gita, what do you want me to do?
So
So we're going to go to the back.
No, I just threw out my question, well, not my question out loud. I'm going to call your attention specifically back to the South African HIV Society's guidelines. It was published in 2021 that has all of these people's comments in it around how this works and cites all the evidence that you're seeking.
Thank you. Belinda?
Thank you, everyone. My name is Belinda. I'm the legal and health programs manager at Gender Dynamics. Perhaps just also a response to the lady over here who spoke. I think first of all, as a transgender person and as someone who works with children specifically on the ground, and who understand the struggles that children has to go through of not being accepted, of not being heard, and for you to sit here perpetuating the same narrative that the anti-gender movement is perpetuating in order to invalidate trans people is also a sign of trans intolerance. Secondly, I want to perhaps pose this question to Anastacia around specifically on our engagements when we engage. We do a lot of advocacy work with the Department of Health, and there is work, right? There is work. We are currently engaging with the Department of Health in the Western Cape. There is definitely the governmental work. And I think one of the issues that we are struggling with is the government is saying that we don't have accurate population size estimations, which means that this then affects the budgets. So they can't budget for the decentralization of gender-affirming hormones to primary health care. So I just want to just ask a question around, is there budgetary implications on, as someone who works in this, is there budgetary decentralized, and what does that make parents look like?
I think the doctors need to speak.
Yeah, thank you, Belinda. So, Ron, before we go to Dr. Anastacia, do you still want to comment on this comment here, or do you want to? Sure. Okay, thank you. And then we will bring the question back to Dr. Anastacia. I just want to close this conversation here.
Specifically on the first comment, there are links being put in the team chat. Someone had asked the evidence that is referenced. The links are there. If you have the link, we can share that with you afterwards.
Thank you.
Yeah, just the thought that was in my head is absolutely. So I'm a social worker, so that's where I come from. Social workers are all about, particularly the children. I mean, we are the profession that are deemed the guardians of the children in the country. The Child Care Act is very much our profession's, kind of call to action to take care of children. Transgender and gender diverse children are also vulnerable children. So your concern around vulnerability, there's a range of vulnerabilities when it comes to the realities of children in our country. And a particular group of vulnerable children are also our transgender and gender diverse children, around which there is, and thank you for the people that are sharing the links and the evidence, please do go have a look at it. And we're already at a point where the evidence has already informed and shaped best practices with regards to working with children. And for many of my colleagues that have been working in this field for many years, I can just reassure you, I have worked, I'm yet, and it does happen, and it's a very, very low rate that people change direction, for example, when it comes to their transition, trajectory. I have yet to have worked with a young person who has gone through the process and regretted where they went. I'm not seeing any evidence of that of any significance other than people with particular genders shouting loudly and trying to create fear, and what lies behind it is the problem. Because the evidence.
Thank you. I think we can, let me just use this. So, Dr. Anastacia, Belinda.
Yeah, where to start? I just want to thank my fellow panelists for the opinions and the insights that you've rendered. There's something that does need to be said about evidence, and that's that people are very good at weaponizing it. I don't know how many of you have ever read the scientific journal. That shit is not easy to understand. Unfortunately, when a journalist gets a hold of it, it's very easy to draw conclusions that are not actually present in the data. And we've seen this, it's been manipulated. You know, if people cite something called, you've probably heard of it, the Swedish study. They like to cite the Swedish study as evidence that surgical intervention for trans people doesn't improve outcomes. It's not what the Swedish study says. They did take a sample of transgender people who had undergone surgery, and what they found was that after surgery, you still need psychosocial support, because otherwise you remain vulnerable, because you're a trans person navigating a world that is inherently transphobic. And as Ron said, children are vulnerable, trans and gender diverse children, doubly, no, triply, no, quadruply so. We know that fully reversible, proven to be safe interventions that are applied, and again, there's a lot of misinformation around when they are applied. We know that these interventions are safe, and we know that they save lives. The interesting thing, and we all remember COVID and vaccines, and the politicized debate around vaccines and masks and so on. And it was baffling to us as clinicians because the evidence was so clear. And we thought, how do people ignore the evidence? So they did studies, and they found out that evidence isn't particularly good at affecting someone's perception or opinion. What is good? Individual narratives. Funny how, as a society controlled by power dynamics that lean heavily in favor of those who are not trans, who are not gender diverse, who are not queer, who are not people of color, who are not people of power, co-opts those narratives and ensures that those voices and those stories are never heard. We on the front lines, we do see them. We see the effects of gatekeeping. We see the scars and the injuries of self-harm. We see the substance abuse. We see the effects of homelessness. We see the effects of bullying. We also get to see people blossom when they are affirmed. And I've had so many of these kids and their parents sort of cross from me. And I've had the parents look me in the eye and say, I no longer have to worry every time I leave the house whether my child will be alive when I get home. Belinda, you asked a very, very good question. I must address it. Sorry, I must address it. Budget is driven by data, and data is driven by budget. Yes. And it's particularly difficult because when you deal with a marginalized population like trans folk, it becomes very difficult to count them. You know what they did before they shipped people off to the concentration camps in Germany in the 1940s? They counted them. When you start to count marginalized folk, you become very scared, and for good reason. And again, this ties into what I've said, because there is a power dynamic. There is a power dynamic, and it comes back to what Chili said, us versus them, and we look at marginalized populations through a lens. We study them like animals in a zoo. Why are we so bad at collecting the data because we don't get the marginalized people to collect the data. We do not empower them. We do not put them in positions where they have access to bursaries, to scholarships, to end-tertiary education, to become the researchers. Because if you come to do census on me, I will not be threatened. You have the lived experience. You know what it's like. You know how to keep it safe. And this is what we neglect to see. And this is the problem that we have to address. So part of the empowerment and the upliftment that is inherent in any discussion around human rights, which is the discussion that we're having, has to recognize that power dynamic and attempt to dismantle it. And what I will say is that the excuse that we do not have the data is a poor one. Because yes, our scenario is different, we're in a different part of the world, we have different socioeconomic standards and so on, but there is a huge amount of data globally to say, or to estimate, how many trans people there are. It would be foolish to think that our statistics would be vastly different. Let us not have such hubris in thinking that if overseas 1 in 200 people are trans, that somehow in Africa it must be 1 in a million. I love to talk about the concept that is often brought up against us to say that queerness, homosexuality, transness is un-African. We've all heard it. And the truth of the matter is that across every continent on this planet, every culture with a documented history, if you look back, you will find evidence of folks who did not conform to today's societal expectations and rules of sexuality and gender. And in fact, the majority of those cultures venerated, treated with great respect, these people who were different. These were the healers, these were the shamans, these were the spiritual leaders of their communities. What came across the seas on boats was not gender ideology. It was transphobia.
So which one? So let's just everything front, back, and then this one, yeah, and online. Yes. So can we just point out the one first, this side?
This hand has been up very.
Yes. I just wanted to say thank you for saying that to the both, because whenever I hear studies about UKs and stuff, I get the colonial shivers. Within the South African context, and as an activist, I will tell you, I will not listen to you. So, thank you.
Hi, I'm Erin Bush, a very recently qualified social worker. And actually, back to Elliott, your discussion about medical aid and the lack of affirming in that. I know that the national health insurance has kind of been floated for discussion for potentially being tabled as a bill. Do you think that provides a realistic avenue to become more inclusive, to actively, provide a much broader, inclusive sort of way to work with trans and gender non-conforming people?
In the next sentence. That's a good question, but I don't know that much about the national health insurance. If it could be part of the package, yes, that would be amazing. That would be so amazing, because currently there's 2 medical aids that will cover gender-affirming healthcare. One is medical aid, one is discovery, but only if you are on the most expensive plan and you have been for like 17 years and your grandfather was also a founder.
There's a 20% copay and there's a cap. 200,000 rand.
There you go. So that's your one option for medical aid. If you are on that level, that tier of medical aid, you can most likely pay for it cash too. Honestly. It would have been cheaper than paying for premiums. The other medical aid that pays for it currently is GENS, I believe. Yeah. Which bodes well on some level, I guess, for hoping that it'll be in the NHI. But I don't know how linked those are structured. But it would be great. Let's advocate for it.
Yeah. Can we just move to the next question? Can we just get everyone's questions in? I don't want to miss anyone. And I don't want to be, attacked when we move out here. So can we get their questions asked? Thank you. And then we move to Shante. Can we just make sure that we also get the questions of the people online? Thank you. That question online. Let's just finish up here, and then we can move to the online.
So my name is Ron Addinall, Tomson. I'm the keynote facilitator. And I just want to recognize in the first instance that this conversation is about listening to people who are not usually listened to in the environment like this. And that notwithstanding, I think that the conversation is about different topics that we have to engage in, and not in the way of proving each other or points of fingers, but rather reaching that kind of separate and speak. My real point this afternoon, though, I'm trying to shift the conversation to the way forward, because I'm very caught at the moment in a curricular transformation space. And I can't tell you, etc. to Chi, because I won't say your whole name properly. The notion of a social psychobio model for engaging with patients is just almost mind-bending, and I'm not surprised that he turned into social worker. But I wonder if the panel can just reflect a little bit, because you're right, Anastacia, about the fact that there are little spots in the curriculum where a particular activist type person is inserted, whether it's queer medicine or trans issues or whatever, and some of the things get then dealt with only from the, like for instance, a thing like the intersex will be dealt with from the pathology of it. So I'm interested in how you construct in your mind the curriculum, because one of the things that I'm aware of is that creating niche spaces for things all the time is not always productive. Because usually it happens very early in a person's career training, and then doesn't happen when it really matters. I just want to get a sense from you about when you say curriculum change, what does that look like? And where would you like to tell that story? Because I think that's a key point that we're at as a school for health sciences.
All right, thanks so much. It's a very important question, and I really would like to jump in with my take on it. I teach not just medical students, but a lot of qualified medical practitioners about gender-affirming care. The one thing that I don't teach them is estradiol valerate, testosterone suppionate, 200 milligrams per mole, 0.3 milliliters per week, because it's not important. You can look it up. The information is out there. My job is to make you want to look it up. No, my job is to make sure that when you encounter a transgender patient, which you will. If you haven't, you will, I promise you. That you will not damage that person. Now, I'll very briefly relate a story of when I joined my current private practice, which I now manage, but I certainly didn't manage it when I joined the practice. We have a little form at the door that people fill in to tell us who they are. And I took a look at this form, and it had the kind of tick boxes that we hate, male and female and so on. And I said to the partners and the other doctors in the practice, listen, this is no good. We need to be a little bit more inclusive. And I suggested, let's put a field where we capture people's pronouns. Let's put a field where we capture the name that people would like to be addressed by. And there was a little bit of pushback because the partners in the practice said to me, well, what about 90-year-old Mrs. Cohen? isn't she going to be offended when she comes in and we're now asking her for her pronouns? We've been asking for 5 years on that form for people's pronouns. We've had not one single confused or offended Mrs. Goldberg. We've been asking for the names people use. Funnily enough, not just the trans folk use that field. A whole lot of other people do, because there's people who have nicknames, or they go by their middle name, or whatever it is. Why am I telling you this? Because when we make accommodations or provision for the specialized needs of marginalized folk in society, there is a rhetoric that we do so at the expense of everyone else. But in fact, everyone stands to benefit. Everyone stands to benefit from these kind of accommodations that are centered around respect, dignity, and human rights. To come to the question of what is important in crafting curricular change, it is to ask the people who are affected. It is to assemble an advisory board of trans-identified people, of queer people, and to get the input. So I think it's very important to assemble a group of people and to say to them, what should we be teaching in order to improve the experiences that you have when you engage with the services that our graduates are going on to provide? And the answer will not be in the specifics, in the surgical technique, in the dosages, in the medications. It will be in the fundamental concepts around human rights. And it all comes back, there's only one thing that I ever talk about, and that's narrative agency. That's really all I ever talk about. It is about listening to someone's story, hearing their experience, believing them, giving them the space to make it heard. And I've been cooking it for the past couple of, longer than the past couple of months. It's been years in the making, but it's on the verge of coming to fruition. We will publish research in the next couple of years on narrative agency and the effect that it has in the healthcare system. And I'm confident, maybe this will come back to bite me in the ass. I'm confident that we will prove that just listening to someone's story and giving them that platform and hearing their voices improves the outcomes, the measurable health metrics. Let's have this conversation again in a few years' time.
But
you have to prove it.
But we have. Oh yeah, so it doesn't count. This is true. Yeah, we're not medical doctors. We're not people. I want to add to what Anastacia said. I think this is the basis for changing the curriculum, whether it is for medical students or for psychology students or social workers or whoever. And not only in relation to gender, in relation to all the axes of inequality, in relation to disability. I mean, think about disability and universal access. Now, someone in a wheelchair still struggles to this day to get places, most places, honestly, right? So it's not only gender, it's everything. So this idea of framing it as in terms of human rights and thinking about it in terms of narrative agency, I think holds a lot of water, a lot of potential. But I also want to say this is an opportunity for the academy to be creative. Universities are filled with smart people, right? That's why you're here. There's a brilliant, Lionel? Yes? You're the dean, you say. There's a brilliant young anatomist in the audience, Ruan, who can talk to you in depth about thinking about anatomy from a not binary perspective, in a way that doesn't take away from anything. No science, doesn't take away from science. Yeah, rest assured, science will be okay. But it's about thinking in new ways. It's a challenge. Take it up.
Dr. Chili, you, and then I just want to go back to some of the questions.
Let's see how that goes.
Yeah.
What I wanted to say in terms of curricular change, what I mentioned earlier about language use, small but big, instead of when the patients come to us. When we see a doctor or when we seek healthcare, what would make us feel better? Because to close that gap between us and them. And then another thing that's come up for me, and it's initially through my sexual health training and now with gender affirmation and with mental health, the concept of informed consent, how we think we know what it is, but none of us do it in practice, even if we think we know what it is. Small example being if someone is depressed and maybe we're discussing starting medication, and then if I'm the doctor sitting there saying, would you like to start these meds today? Can I write you the script? Or would you like to think about what we discussed today? We come back, we can chat again. Because theoretically, we're not supposed to get consent for an intervention at that exact moment. So then I use that with my clients and my patients all the time. My job as the medical professional is to provide you with medical guidelines and suggestions that have the best evidence or have the best standards. My job is not to implore you with my personal opinion. And it's something I say all the time. Your personal opinion is never indicated in the clinical room. Your personal opinion is never indicated in the clinical room. So, unfortunately, during our training, we do get told we're very clever, we know what's going on, we're cream of crop, yada, 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 yada. And then we come out as these weird individuals that think that when I tell you my opinion or my suggestion, it should be taken without a doubt. And so even if I think I know the best medication today to help you with your fatigue, if when you look at those tabs, they're too big for you to swallow and you don't like this or that, if my intervention to you is not acceptable or accessible, it might as well not be there. And so the discussion around where someone is at and meet you somewhere along your pathway, my role is actually quite small. In the time we are together, it's 50-50, our shared responsibility for your health, and when you leave, it's all on you. And so I think a lot of us as clinicians, we completely overestimate what we should be doing in certain areas and completely underestimate it in other areas, where just with that one person, as Anastacia was saying, to hear them and listen, so that when you're leaving the room, instead of me feeling like a clever doctor doing lots of investigations, have I actually heard the question you were asking? And I think did I answer your question? That's one of the things I often ask people. You've asked me something, did I answer your question? Are we actually meeting each other? If you don't understand me, it's likely because I didn't explain well. So let me try and explain a different way. And different types of informed consent. The way we do things in med school, we go up to the patient bed, we're all learning to do blood, and we're basically just so nervous that we're going to mess it up in front of all our peers. And then there's this thing of we go to the arm and we expect the arm to come out. And we don't say, may I take your blood? I'm now going to pierce your skin with a needle. Or when it comes to putting in drips. Or when it comes to doing per-vaginal examinations in a gynae ward, or. So as a medical fraternity, we've taken a lot of liberties. We've taken our patriarchal privilege, and we have completely obliterated people's agency with us. And so sometimes people will say to me, Doc, what do you think I should do? And I say, well, I mentioned you have an ear infection. There's drops for oral antibiotics. These are the pros, these are the cons of either. Usually I quite like it for someone to pick what they want. Very few and far between someone will say, no, Doc, you pick for me, you pick, that's why I'm here. If you'd like me to, sure. But otherwise, the only times I'll decide something for someone, if you tell me you cannot make the decision for yourself today, sometimes it happens, especially with mental health, or if you're saying, no, Doc, that's why I'm paying you the money, you tell me, cool. Otherwise, I provide you with options that are available, and you make the choice. There's no directive anything there. So, picking apart informed consent. Oh, I said I was going to be quick.
It seems like we're liars, but anyway, coming back to the point, can we just ask these questions? There was a question this time, and then you, and then this is the point, and then I'm gonna ask can I just ask, please? So can we just have the hands that have answered the questions and we go there and then we go to the people? Because everyone put up their hands at once, I don't, I only have twice. We're still doing research for the third one, so.
Yeah, there was two. There's still questions here.
Can we
I wanted to just make a comment before we continue because there's quite something happening in the Microsoft Teams chat. Yeah, a lot related to one of our first questions. It's a lot of questions related to very specific incidences, very specific cases, very medical questions. I think we're all quite aware that we did not come to a seminar on surgery. We did not come to a seminar on hormones. This is a panel discussion based on gender-affirming healthcare, working from the premise that trans people exist, trans people are real, trans people should have rights, trans people should receive healthcare that is gender-affirming, safe, inclusive. And if you have been able to read a very problematic example, a very intrusive, invasive, problematic example on Google, then you've also been able to have access to the information that debunks that. Please, we have clinicians here that work their butts off for trans people in this country. They are trans people themselves and they have years and years experience working with trans people. Please ask them questions related to that, because if it's a question that you can Google, quite frankly, take out your phone and Google it.
So, you have another hand this side, or can I move to this side?
Over here.
Oh, thank you.
Hi. Thank you. My name is Giles. I'm a trans woman in biomedical engineering, and my studies involve HIV. And something that I discovered when doing research is that on the stats I found that the minority with the sort of biggest vulnerability for HIV in South Africa is transgender people. And that was not something that I, even as a trans person, I had any awareness of before going into that. I mean, you know, if you'd asked me, I thought I maybe would have thought of it, but it was never publicized. You know, we learned a lot about HIV, obviously,
yes.
It's such a big issue in our country, but that had never come across my sort of vision before. So I was wondering if any of you could speak to that.
Yeah, can I just answer maybe you on that question? In 2018, the Human Science Research Council conducted the first biovariable study amongst trans women. I was part of this study, just for all of you to know that I've screened all of the people coming there. But also that is being published in the DMC journal. So trans women are 49 times at risk to contract HIV in South Africa based on why we say that the social disparities and all of this access to gender-affirming healthcare. But we have also become the targeted so for HIV implementation programs. Everyone is jumping on the trans wagon, but yet they don't want to acknowledge us. Do you understand? So yes, so there is publications out on the HIV prevalence amongst trans women. Next question. So it's you. And then there's three at the back, and then going to the, yeah.
You have to let me speak. I want to thank my panelists for their restraint, and I want to thank everyone for indulging me in what is going to mostly be passing comment, and circling back to the issue of children, and children's agency, and informed consent, and trans children, because I was a trans child. And I knew that very early. And I knew that very firmly. I recall being about 12, maybe 13, and I knew what I wanted. I wanted to be a girl. I wanted to go to school as a girl. I wanted hormones when I was old enough to safely take hormones. However, I was also, like I said, 13. Okay, you have to be 16 to consent to hormone treatment. Even once you're 16, getting access to it is very difficult. But at age 13 or so, I went to my parents and I said, I want hormones. And they said, what have you done? They said, what if, even if you are trans, whatever that would mean, we let you transition, and it's so difficult, it's so stressful, that it brings your marks at school down, Alice. You're an all-A student, Alice. Why don't we experiment with keeping you presenting as a boy through school so that you can get your marks, and then you can go off to UCT and you can transition once you're at UCT. And I said, fine, I'll go with your experiment. I will, in a situation where you are the one who consents to which puberty I go through, I will let you run this experiment on me. It's going to make you miserable, but you are my parent. I got to 16, 17, and this issue was revisited once every 6 months in that time frame. And when I got to about 17 and a half, I'm on the verge of turning 18 now, I'm still running with this experiment, even though I could consent to hormones on my own accord. I went back to my parents and I said, this time, it's no longer, why don't we let me stay as a boy, make it through school, do well, and then go off to UCT. No, now it's either you give me the hormones or I kill myself. And then I was given the hormones. And just on an interesting note about how we police ourselves, I got the go-ahead from my parents to get the hormones. They were no longer going to do anything if I went and asked for hormones. I got a go-ahead from the doctor who was going to prescribe me the hormones. I still then took 3 months to send an email asking for the script. Because after years of this, after years of knowing there was no alternative, I still wanted to be absolutely doubly sure. But as a trans child, then a trans teenager, now a trans adolescent, I want to know that at no point did any medical professional experiment on me. My parents experimented on me by denying me access to trans healthcare. And once I acquired that trans healthcare, I absolutely thrived. Thank you.
My question is yeah. So the question is here at the front. So yeah.
Transfer and green behind, and then we go back.
Can you see them? Can you see them? Mute. Let's Phillips.
Hi everyone, can you hear me?
Hi, Penny.
Perfect. Apologies.
Can you ask my question? I will just make the question online, please.
Yeah.
Yeah.
You can ask the question, just quickly. Let's respect everyone who wants to ask the question.
Hi, colleagues.
Can you hear it?
Can you hear me?
Just unmute your
Yeah, bad idea.
Hello? Okay, so I can't hear you now, but Gita, you can just show me if you can hear me with your thumbs, maybe. Perfect. So, colleagues, I am online and I am there. I am literally following. I had to skip my online class even to be in and out of this session. Because I think this is an amazing and a very important session that is being hosted. I think my question relates to what extent are government policies and institutional policies effectively addressing the systemic barriers experienced by trans and gender diverse persons in the world, specifically in South Africa. And I'm not just speaking about in access to healthcare, but also in education. Currently, we have the issues of the socio-educational guidelines that is not yet adopted to protect the rights of trans and gender diverse children in schools. So I think as much as we do have these critical dialogues and these critical conversations, I think we must also perhaps unpack what it looks like to educate. Someone was mentioning, Dr. Anastacia was mentioning that we educate and we raise awareness and so on. And we've done a lot of that. We capacitate. So my question is around to what extent do we hold accountable and how do we effectively hold accountable, yet educating and capacitating institutions, schools, and let's say healthcare service providers, because we don't want to, we want allyships, right? And so considering that sometimes we we're almost silenced in a way by the fact that we want to partner with an institution, or we want to partner with a certain service provider, right? Because we need it as an ally, but then we keep quiet on the critical issues at hand. So how do we hold accountable and yet, kind of like have these relationships that is needed for the work to move forward in a positive way?
Ask Ron to give you a answer to that. Will you?
I was saying, don't ask small questions.
Oh yeah. So Ron, will you thank you?
I mean, I think that's a critical question. I don't know, I don't have a ready formed answer to it, but I think, and you see that you're highlighting an important space or place in the, I'm going to use a naughty word now, in the transgender agenda.
Where's my testosterone shot?
So absolutely, it's that tension between we are needing to partner with people who have the power. Going back to Anastasia's points earlier, we are reliant on government, state institutions to partner with us here and who have the power to put the necessary, in place. And before things can be put in place, there has to be policy, there has to be legislation, and I've been part of the Department of Education process that you mentioned. I think it's since more than 10 years that we've been working with the Department of Education to try and get this policy sorted. That is still not published. It's been in multiple various forms. And then the tension is about accountability. So how do you put your activist hat on and literally put your hand close to the throat of the people of power and say, you have to step up. This is unacceptable. But at the same time, you're afraid of, well, you're going to piss them off. They're the people with the power. So I guess I'm not answering the question. I think I'm just giving more detail to how tenuous that situation is, and that I think there's more work that needs to be done, that we find the confidence in our voices to ask for and demand for and hold accountable and not become afraid and step away because these are the people with the power. But the how to, I don't have an answer to that.
Elliott. And then coming back to your question and then we...
For me, so yes, we need to hold government and all organizations accountable, right? We need to figure out ways to do this. But for me, ultimately, this is about humans. Yes. This is about the humanity of people. Yeah, I actually don't want to say anything else. It's about humans. And if we are a country that claims to embrace human rights and we pride ourselves on that, then we must think about what are we doing to humans. Yes. We laugh about these things and we joke about the transgender agenda. But it's always a kind of a bittersweet laugh. It's always a bit like, not again. Yeah. So yeah, humans. We're humans. I'm a human. I get hurt with these things.
Yeah, just on the transgender agenda, I mean, it's just vibe, really. On the question of accountability, and Kanye, I think it's such an important question. And it is a difficult one to answer. But we have this concept called allyship, and everyone wants to know, how do I be a good ally? Is it by loudly proclaiming at a dinner party that I'm friends with at least one trans person? But what we have to realize is that when we speak about marginalized groups, we think about society through an intersectional lens. People who are not trans, who don't have this lived experience, do wield great power in society. Their voices are heard and treated with a lot more deference and a lot more respect. And it's so much of what we're talking about, the decision makers are people without lived experience, and it's that power dynamic. So if your voice is one of those that is more platformed because you happen to not be trans, and you find yourself being a proponent of human rights, and you believe that trans people are in fact human and that should be accorded those human rights, then you have power that you can use in order to hold these institutions accountable. And we're all familiar with the concept of the customer is always right. And who are the customers of the government, of Department of Health, of Department of Basic Education? It's we the people. We are the customers. And it goes doubly for universities. I tell this to the students. I tell them the university is a business. I'm sorry, Ron, university is a business. And the students are the customers. And you have power. You are paying their salaries. Recognize that you have power. And this is something that happens especially in South Africa, is that we all have this like, we'll take the scraps mentality because that's all there is, that's all there's ever been. And it is this concept that is sold to us to disempower us. It's not that we don't have power, it's just you convinced us that we don't, and we believed you. So if we start believing that and we band together, and people who have more agency and better platforms and voices that are heard in society actually use those voices in order to support people whose lives are in danger on the basis purely of who they are, not decisions that they made, not any political affiliations, not any religious affiliations, just purely this is who you are, how you were born. You are in danger, jeopardy, physical safety is at risk because of that. If you want to stand up for those people, you have the power to do it and to hold these institutions accountable. We do our best, but there are fewer of us, and it's up for debate as to whether.
Yeah. So I'm going to get the last three questions. We did start a little bit late, so I want to take the time. Yeah. So you let's do it me, Len, and Viola, and then we.
Right. My name is Tessa. I've been a GP for about 40 years, and I am practicing in the dreaded National Health Service in England at the moment, coming back and forth. But the dreaded not-for-profit, evidence-based health service. And we have recently been looking at all the data. I work with transgender patients, I work with children distressed about their gender, and we've been recently going through all the evidence. And first of all, weaponizing suicidality, I think, is unethical. It's deeply problematic because what the studies seem to suggest is that the suicidality seems to increase in our patients who are puberty blockers and who put onto hormone medication. So I hear laughter, but we have to take evidence seriously. I trained at this university as a doctor. I trained in evidence-based medicine, and I sit here and I hear all of you people saying like, oh, evidence is not important, or there is the evidence. Why do we have something called trans-exceptional, which I find deeply transphobic, quite frankly, that I would treat my transgender patients differently from any of my other patients. And that's an insult to me, that I would treat my children who are distressed about their gender differently from any of my other patients. And I'm really concerned about this. And I'm concerned about the level of...
Is there a question or was it a comment?
So it's a comment, but it's also, we see, unfortunately, what we see is more and more people who are detransitioning and regretting. Where do we...
So let me just quickly just on the last part. We are still struggling to access the healthcare. Talking about detransitioning is not even part of this. And secondly, my next question is, you're talking about evidence, where is it, in the UK or in South Africa?
It's internationally gathering.
No, but I'm talking in South Africa. Because we can't even think about detransitioning as we are still fighting for access to these services.
Yeah, I think we're in different positions definitely in the National Health Service, but that doesn't excuse bad science. No one has said that.
Yeah.
Bad science.
Yes.
In this actually,
do you want anyone want to
say something about that?
Can we just respect the space quickly? Can we just ask this lady a question?
Yeah,
and then we can comment.
Thank you.
Thank you.
So I have been very patient. I'm Joanne Russell. I'm a professor in this institute and I'm an HIV prevention scientist, but I'm also the mom of a transgender girl, and Dr. Anastacia is a doctor at the moment. But I just wanted to say to this team, but also to Kotze Hospital, Simon Pixton Taylor, Michelle Careyville, and the Adolescent Clinic, wow, I'm so proud that I work at this university that has afforded my daughter this opportunity. So I just wanted to say that. It's just about the issue for me that has been discussed is gatekeeping, that transgender girl to change her gender markers. She needs 2 medical professionals to say that she is allowed to. She needs a medical doctor to put on hormones. So there's, these are allies, but yeah, there's a lot of gatekeeping. That is a huge source of anxiety.
So just a comment from Dr. Chili, and then the 2 questions at the back, and then you can have your moment.
Thank you for that comment, and then come back a little bit, go forward a little bit. I think when we practice in a way where we actually use informed consent as a process and not a checkbox, yes, we will have less issues where suddenly someone started something and suddenly it got worse. So what I mean by that is, if and when someone wants to see me, and if we are talking about gender-affirming HRT, or if we are talking about medication to alleviate certain mental health conditions, or medication to alleviate pain, where I meet you today, I can't assume that that's where I'll meet you next week. And so informed consent and consent as a process of sharing information as it becomes aware to you, as you become aware of it, is a lot more helpful on an individual basis, whether seeing a child, adolescent, or adult. And that is potentially something that perhaps if we practice in a more informed consent way, we wouldn't find ourselves in a position where suddenly people are feeling as though they didn't have agency. I also find it to be an interesting double standard that suddenly regret is being used as a proxy of, I think this is bad medicine, as opposed to regret being used as a proxy of regret. Because if we were to go and look across all kinds of literature about medical interventions, even if it is a total hip replacement, or if it was the surgeon took out the appendix instead of trialing 24 hours of antibiotics, and if you ask one surgeon, they'll say, oh, that's a cowboy treating you conservatively there, and someone else will say, wow, you let someone cut you open. So it's quite important that it's case by case, individual by individual. Yeah.
Thank you.
Excellent, Julie.
Okay, thank you. The 2 questions at the back, and then your comment. So you are the last. There's 2 questions at the back. Do we have 4 questions online?
Yeah, that's one question online. Yeah. Hi everyone, I'll try to keep it brief. So my name is Lynn Duss. I'm the long title, the Research Project Manager for the LGBT+ Health Division at the Institute Health Foundation. Thank you to everyone, the panelists, great discussion. We need more of this, please, Shantae, just get everybody in the same room talking. Access in rural areas for gender-affirming healthcare, I think it's struggle in urban areas to get access, but what are different strategies, mechanisms, ways that we can think about getting access to rural healthcare? I mean, some of the panelists were partners with us in going to Central Peru last year, and know of people who are spending a full day, their own money, traveling down to Cape Town just to access hormones at FITS, because that's the only way they can do it. And I mean, those are the lucky people, right? Yeah. So how do we think about strategies to increase access in rural areas? And my second is the NHI comment. So also a health policy and systems researcher, and part of my thesis was to read all 5 iterations of the NHI bill. And in not one single one of those is trans and gender diverse people
mentioned. So part of the problem is they were after the NHI, there's been several roadblocks, and I mean it's progressing slowly, but there hasn't actually been a benefits package that's been kind of published yet. So what we need to do at this point is advocate for gender-affirming care to be part of the minimum benefits package, similarly to like prescribed minimum benefits in private sector medical aid, to say, and we need evidence and research and data around this, but to say this is how many lives we're going to save, this is the cost effectiveness, and this is why it should be part of national health insurance. And we have a lot of important people in the room that can be part of that advocacy as well, but also to say that we shouldn't wait for national health insurance to come to think about how we can all collectively strategize towards integrating access to gender-affirming healthcare into our public sector and our health system.
Thank you.
But in the sense that started. The question I have actually as a trans woman and dealing with this problem on a daily basis as to we have been told that with taking on emotions will come along. But how do I explain to society about my emotions? Because at days I will wake up and be happy, and the next minute I'll be sad, and the sadness will last for up to 2, 3, Lord knows how long. So how do I explain that to society? Because they judge me on my emotions. I've heard that I've heard the ugliest thing about just being sad and being depressed for no reason. So that's my question I have for the panel. Thank you.
Thank you very much.
All right. Then let me come to your question first, which is how do we really expand access in rural areas? And the two obvious answers are either we bring the people to the services or we bring the services to the people. We live in a post-COVID world. There's such a thing as telehealth. Like, just pardon my language, but like, just fucking leverage it already. Like thousands of kilometers can be narrowed through an internet connection. And there are ways to get data. There are ways to get data. Corporate social responsibility, Vodacom, MTN, we look at you. And again, I'll come back to what I said in response to Lionel earlier. It will benefit everyone, because what else they don't have in rural areas are all of the specialists, and those patients need them. So it's ready. It's just time for us to get with the program. Then Viola, for your question, what I want to say is that fundamentally prejudice all operates on the same principle, and misogyny and transphobia are not fundamentally not different. And this is rooted in misogyny. We've told women for generations that they're hysterical, that their pain isn't real, that their complaints don't count, that they should just push through it, etc., etc., etc. I've treated I don't know how many iron deficient women in my practice who have been told by every other doctor that they just deserve to be tired. Like, it should be that much more difficult for you. And if you were a good human being, you would just try harder. So really this comes down to misogyny, and it comes down to the toxicity around expressing emotion, showing our humanity, and the perceived weakness that comes along with it. And don't get me wrong, women suffer, trans women suffer especially. Men also suffer, because this is exactly what tells you that boys don't cry. This is exactly what tells you that you need to objectify women in order to fit in with your peers. It all operates on the same axis. It does not benefit any of us. These concepts were all established by a group of old white men in togas sitting around in a stone amphitheater many thousands of years ago. They're all dead and buried, but we hold up their principles with a sacred reverence. We hold to it. And again, all I ever speak about is narrative agency. You didn't buy into this, you didn't sign up for it. No one put a contract in front of you that says, do you consent to misogyny? And you said, yes, absolutely, sign, agree. Your agency has been co-opted when you buy into these ideas. And we take it for granted. We never do the introspection, we never do the interrogation, we never say, is this something that is in line with my own ethical framework? Do I really believe that women are inferior to men or trans people are inferior to cis people? You absorb it from the zeitgeist, from what you see at school, from what you see in the media, or what you don't see in the media, because the lack of representation is also a statement. And you buy into it, and in that process, you have lost agency. And especially when it comes to clinicians, and this is really where I get very passionate about it, and this is why we have to do the research, is because you take a group of people who, the majority of us, I mean, some people get into medicine for the riches of it, jokes on you. Shit my pants at the end of every month, the debit orders I get, it's just the way it is. So there's no medicine, but the majority of us got into it because we actually want to help people, and I think it is so tragic to take a group of altruistic, self-sacrificing people who want nothing more than to help their fellow human beings, and you subject them to systems and institutions that systematically erase not just their humanity, but their understanding of humanity around them, and empower them and encourage them to persecute and trample upon the human rights of the people that they actually wanted to serve, and not just encourage them, but penalize them if they don't, for that group of people to have to look back someday and realize I violated every single one of my own ethical principles. I trampled on those human rights of the people that I really wanted to look after and help and protect, and I did it without even realizing what was happening. I think that is tragic, and I think by encouraging and fostering scenarios and environments and institutions and a culture where we encourage people to be in touch with their humanity, where we realize that this is not in conflict with the professionalism, with donning a nondescript white coat and amputating every nuanced part of our identity and personality, I think that we will improve everyone's experience, and I think will help to resolve what you're complaining about, Viola.
Thank you.
When it comes to it's not always, it usually isn't because they're not the identity they identify with. It's usually because of the ramifications that happen after one person has transitioned, because everything changes, how people perceive you, how your family members relate to you, how you interact with people, how you're seen, how it all changes, and sometimes that can be really difficult. Really difficult, because you can lose people, you can, and you end up losing yourself a lot of the time, because it's literally learning how to be a human all over again with a whole new perspective, losing the support systems you already had and having to relearn this new way of life. And when it comes to the regret rates, relatively the detransition regret rates is really low, it's less than 1%.
We don't know that. We don't know. I wish we knew that. We need to do some research. We don't know.
A lot of research says
it's talking high, so we don't know that it's high.
The other thing that also happens is people who do end up detransitioning later on can transition again. because it wasn't necessarily that they were uncertain about their identity, it was because of all the elements that were pounding on. Like, for example, like I'm a queer, genderqueer child. And there's some days where it's like, am I really I like things? And there are a lot of things out there. But apparently a man can't be feminine, that means you're gay, right? No, it doesn't mean that. And if a woman is masculine, that means you're a lesbian. No, that it doesn't mean that. It's like you cannot be yourself without someone projecting something onto you, and that can sometimes really mess up your own trust in yourself and just affect the way you interact with people, and that it leads you to like having to suppress yourself and have to fit in, but that leads to more misery and more confusion, and you just
We're not addressing is stereotypical gender roles in society. We are not even looking at that. And I think that's what needs to be probably change society, not.
And I hope that after today's session, we will have another one like this. And this is just not also a situation where we come together and also big box exercises on this institution. So we would like to come back to this faculty to have these conversations again. You understand? So, Shante, I think from my side, any closing comments from you, Dr. Anastacia?
Yeah, I appreciate the opportunity. I feel like I've said just about everything that there is to say. What I do want to say is just, and I touched on it earlier when I said we need to teach our healthcare professionals, because if you haven't treated a trans person, you will treat a trans person. But it applies to everyone in society. We exist. There are more of us probably than even we expect that there are. Because you don't know. You don't know. You look at people, you can tell nothing. There are so many people who have been denied the opportunity to stand in their truth because of the consequences thereof of the situations that they're in. And those people remain invisible. But the fact of the matter is that as you move through this world, if you're not trans yourself, you have trans people in your life, your family, your friend circle. You pass them in the shopping mall. Definitely you see them in the hospitals. This is not a theoretical conversation. This is human beings. This is human rights. That's what we're speaking about. And it is a conversation around essential services. And it's a conversation that is often around life and death. And for us, Trans Day of Visibility was a couple of days ago. Trans Day of Visibility, and visibility is such a difficult word for us, because as I've said, visibility often means I'm a target, I'm at risk. You know, when you grow up different in this world, people seek out the spotlight. Everyone wants to be the center of attention. When you grow up different in this world, that spotlight is a threat, it is a danger. And every moment of your existence, every ounce of energy, every square inch of intellectual capacity that you have has to be diverted into flying under the radar, avoiding all attention because of those consequences and because of that danger. So we speak about Trans Day of Visibility, and I have to comment on the irony of it, but the counterpart to Trans Day of Visibility, and we'll speak about this again in November, I'm sure, is the Trans Day of Remembrance, where we count the fallen.
Yeah.
The ones that we know, the ones that we see, the ones that are not misgendered after their demise, the ones whose narratives are not co-opted. A couple of weeks ago, the news that came out of Oklahoma in the United States, where a 16-year-old non-binary human being was, I will say murdered, and now ruled it a suicide. That suicide was prompted by transphobia, by the assault that preceded it, by all of the abuse. These are our people that are dying. certainly I can say for those of us who are parent content, many of us in the audience, we have all lost at least someone. It never gets easier. And then we think about how many more we stand to lose. And for many of us, we think about how close to that edge we ourselves have stood. And I will say, so let me not speak on behalf of anyone else. It's a miracle that I'm still here. Maybe it's a miracle for some of the rest of you. But let us not forget what was at stake.
This is something I've said a couple of times now when we have this kind of conversation. I'm tired of having this conversation now. I want to talk about gender euphoria. I want to talk about trans joy. I want to talk about what we call sex trans people. I want to talk about the fun things. I don't want to talk about access anymore. I don't want to defend my existence anymore. Closing.
Firstly, thank you so much for this platform today. Thank you for the invitation and for moderation and facilitating everything. The med school faculty seem to have nice snacks consistently. As well. It's just reinforcing that cream of the crop thing. Thank you to the questions and comments from the audience. I would just end off with today that I echo what Elliott mentions, because gender-affirming healthcare is very little to do with the hormones and the surgery, and a lot more to do with believing someone when they tell you who they are. And so it would be beautiful to have more conversations there, and all that other nitty-gritty nuance stuff that's really fun and maybe difficult as a doctor. If and when I need to chat to one of my clients about, remember, I need to check your prostate, you forgot, I didn't forget, vice versa, about cervical smears, etc., and how, thinking beyond just the access initially to all those beautiful, intricate, nuanced things, and again, about sexual health, pleasure, understanding that mental health support is there for you because you're a human, and anyone who's ever had a childhood can benefit from therapy. It's in that way that we frame it. So if and when you're checking in about things, it's because you're a human, and I do that for everyone, and about all my patients and clients about, are we doing our screenings? Same thing. So I look forward to those discussions. Thank you.
Thank you.
Yeah, the thought that I found that the word that was sitting in my head the whole time is the word diversity. And, one of my favorite sex researchers, being a sexologist, back already in the 1940s, 50s, when Alfred Kinsey started his research, and much research that has followed, and that realization that he had that Mother Nature, however you see her, is about diversity. It's about creating diversity and ever evolving. And that's a core element of what we're speaking about. The transgender and gender diverse people of our human beingness are part of the beautiful diversity. For me, if I had to kind of project forward, we were talking about curriculum, I would like to see that it's normative, no matter which lecture or class is being taught, that the integration of all kinds of people is just naturally part of the example.
Yes.
That it's not niched, because when you niche things, you other it. And when you other it, I guess you can make the deductions there. So I just think we need to embrace diversity, and transgender and gender diverse people bring divine, beautiful color to the diversity of who we are as human beings. Let's love us, let's celebrate us, and take it from there.
I'm sitting here, the shout out to yes. Yes, I want to having Ron here as a sexologist, we didn't even touch on him. So Ron, most definitely, I will hunt you down, we'll come back here again and we'll talk about The sex. Remember, I'm a former sex worker. I know about sex.
You know the practice I know is clear.
Yes. Thank you. But this is for me, Gita November. I'm a proud trans woman. So in the South African context, I'm here to stay. I'm not going anywhere. I will fight each and every system. We will be, and we will not be denied again. So, like Anastacia said, as students of this university, remember your power. Don't let me come and sit here again and talk about your power also, because you need to go and show me that you got me, I've got you.
Yeah.
Thank you.
Okay, sorry, we are a bit over time. I won't be much longer. Thank you for everyone that's still here. Yeah, in line with what's been said, some of the comments from the Teams chat is also about policy work that is busy happening. Someone has said that, sorry to the Dean, I want to see FHS do some research on cisgender trans-critical healthcare providers because something isn't adding up. Something is not being said out loud and I need to know what it is. Someone said that we need to embrace this work with much more passion to trans people and queer people as a whole. Sorry, as I just scroll. Okay. Okay, I think that's all for now. Oh yes, a good comment as well. I hope each person on this panel and at the panel spends the evening processing, resting, and being held. It was a tough one, and you all did a lot for us. And as much as it's appreciated, I can't wait until these talks don't have to be this hard. Your activist sacrifice is seen. Thank you for holding space and for hosting doctors and others who are working to make the world a bit better. It's very comforting, amazing and critical dialogue. Well done to FHS and Gita for holding space for all of us. And there was another comment that I cannot find now about representation. Someone saying that they didn't realize that they needed representation like this on a panel to see not only clinicians but trans and queer people themselves speak for us, speak for themselves, and. And then in my own closing, there will be more events like this. We try and keep them quarterly, and by we, I mean me. So please be patient and please be kind. We are looking at doing something for and around Trans Day of Remembrance. I hope that everyone that wanted to speak about suicide and weaponizing suicide will then come and show up for the ones that we've lost, for the people that sits very close to. There will also be, as there was last year, celebrations during Pride. I hope you also celebrate us. I hope you also celebrate with us. As Elliott said, queer joy, this got very difficult and that wasn't necessarily something we could tackle, but it will be something that we'll keep seeing and that will keep coming. And then I just wanted to say a big thank you again to the audience for coming and engaging in the way that they did. And an even bigger thank you to the queer and trans people in the audience that had to sit through some very, very difficult questions and comments, and especially some of the things that were said on Teams were not easy. And then thank you to the staff that assisted, especially comms and marketing, if they are still online. We work very closely together. Their efforts are invaluable to the success of most of my events, and they deal with hundreds and hundreds of emails and nagging from me. And then to my transformation team as well, that don't stop hearing about me, also nagging and complaining and venting about everything that's going on and everything that could go wrong. These things are not easy, so a big thank you. And then lastly, of course, a thank you to our panelists for taking time out of very busy schedules, time away from patients, away from clients, away from family and home life, We really, really appreciate it. At least I know that I appreciate it, and we would love to engage you further if that's something that you would like as well. And as a small token of our gratitude, I have little gifts for everyone.